second speaker today, Joeffrey Chahine, is the Technical Director of the Molecular Pathology Division at MedStar Georgetown University Hospital and has more than 15 years of experience in molecular pathology. In his role as the Technical Director of the Molecular Diagnostics Division at MedStar Georgetown.
My name is Joeffrey Chahine, and today I'm going to discuss the process that we've been through to bring in the COVID-19 testing and all the algorithms that we had to work out in order for us to be able to test a good number of patients in our MedStar health system. Just to give a very short presentation about our MedStar hospitals or MedStar health system. This is a system that's basically composed of 10 hospitals that are in Washington, D.C. and in the state of Maryland. In Washington, D.C., we have 2 hospitals, and the other 8 hospitals are mainly spread out in the state of Maryland and concentrated around the city of Baltimore. The 2 biggest hospitals for the MedStar system are MedStar Georgetown University Hospital and MedStar Washington Hospital Center. And these 2 hospitals happen as well to be the largest hospital in Washington, D.C. The reason I'm mentioning these 2 hospitals is because at MedStar Georgetown University Hospital, the Molecular Pathology Division is a central division for all MedStar hospitals. And at MedStar Washington Hospital Center, the Microbiology Division is the central division for all microbiology labs at MedStar Health. These 2 hospitals are basically composed of 648 beds at Georgetown and 911 beds at Hospital Center, and they are in very close proximity to the White House and other government offices. So to start with COVID, in February, COVID-19 has become a very hot topic in the United States. And around the end of February, the MedStar leadership have decided and approved that COVID-19 testing had to be tested in-house. And they have assigned this task to both the microbiology and the molecular pathology divisions. In the first week of March, the first COVID-19 patient was identified in the DC area, and he was admitted at MedStar Georgetown University Hospital. This patient was confirmed positive at the Department of Health using the CDC testing. So the pressure was on. The officials from the government have really pressed MedStar Health as being the largest healthcare provider in the DC and Maryland state to bring in COVID-19 testing and start testing the community and associate as soon as possible. The problem was that testing material was not available at that time. And it was very hard to acquire. Even the biggest companies, we were able to ask them for kits. They said, yes, you can purchase them, but they were not delivered. So on the second week of March, I have received a call from the Quidel representative, and they mentioned that they are working on a COVID-19 assay, and they are in the process of getting an EUA submitted to the FDA. So on that weekend, on a Saturday evening, the kits were shipped from Quidel to my division when I received them and I have received them on Monday morning. So what is the Quidel kit? The Quidel kit is the Lyra SARS-CoV-2 assay, and it's basically a qualitative COVID-19 assay. It is an assay based on real-time PCR, and the target of this assay is the non-structural polyprotein of the SARS-CoV-2 virus. This assay is comparable on nasopharyngeal and oropharyngeal swabs, and it is compatible with the viral transport medium as the M4, M4RT, and the UTMs. And it could be also compatible with other assays, with other viral transport medium, such as the saline or the eSwabs as well. Now, this assay as well is targeted so that it could be used in high complexity, CLIA certified high complexity laboratories in the United States or equivalent laboratories outside the US. So this kit is a 96 reaction kit and is composed of lyophilized master mixes. It also includes the rehydration reagents for the lyophilized material. It includes as well a process control, which is our extraction control, and two other controls, the negative control and the positive control, that should be included on every single run when COVID-19 assay testing is performed. Now, how did we proceed with our validation? Right before we received those kits, the FDA has released a statement easing up the criteria for COVID-19 validation. And the reason for that is because the material for the assays or the testing material was very limited, and they did not want laboratories to spend money and effort on creating a very extensive validation rather than testing patients. So they have decided to ease up the criteria for the validation of COVID-19. And they have released very strict criteria for this validation. From our side at Georgetown, what we have done in order to be compliant with this validation, we have collected 35 nasopharyngeal and oropharyngeal swabs from volunteers in the pathology department that are presumably negative for COVID-19. And we have as well acquired two sources of positive controls. The first source was a live virus that we bought from a company called BEI Resources. And the other source was the patient that was first identified as positive in the DC area and was still in the hospital. So we were able to get multiple nasopharyngeal and oropharyngeal swab from this patient as a source for our validation material. So what we have done is basically we have collected these swabs into different media as well, so that we make sure that we are covering as well the viral transport medium criteria that are basically required for this assay. So these nasopharyngeal swabs were collected, 11 of them in Rimmel transport medium, 12 of them in Copan UTM, BD, and then another 12 in the UTM for diagnostic hybrid Quidel medium. So for the validation, we have designed our validation over 2 days to cover the two most important criteria for analytical validation, the accuracy and the precision. The accuracy is basically making sure that the expected results match our outcome. So what we have done is we have tested all nasopharyngeal and oropharyngeal swabs that were collected on the volunteers on basically as original, not being modified or anything, to confirm the negative results, and all negative results were confirmed. Then we have taken these nasopharyngeal swabs and spiked them with the patient one that was in the hospital and that was confirmed as positive patient in order to have 35 positive nasopharyngeal swab. And that was a statement that was released by the FDA because of the scarce positive material in the beginning, is that we can use a positive confirmed source and we can spike that source into multiple negative clinical specimen, and then we can produce our positive specimens. So we have spiked those nasopharyngeal swabs that are negative with a positive source from patient one, and we have tested them, and all of them came back as positive. We have done the same work on the oropharyngeal swab using the second source, that was the genomic RNA that we purchased from BEI Resources. And all these spiked oropharyngeal swabs were positive as well. So our accuracy was confirmed by the end of the day as 100% because all the positive results and the negative results that were expected came back concordant. On the second day of the validation, we have repeated the same process to make sure that we can reproduce the same results over. And the reason for that also, we wanted to cover one aspect of the validation is the freeze and thaw of these materials, especially that we were dealing with RNA, and we know how much RNA can be unstable when it's basically exposed to freezing and thawing, then freezing and thawing. So on the second day, we have repeated the same process, and all the negative results on the original nasopharyngeal swab were confirmed negative. The positive results on both the spiked nasopharyngeal and the oropharyngeal swabs were confirmed positive. So we have covered our precision and reproducibility of results, and the concordance was 100% as well. What we have done as well, and I'm not going to go into the detail of this, is we have covered as well a little bit of the limit of detection, just to make sure that we can also detect very low viral loads. But I'm not going to go into the detail of that, because the reason for this presentation, or the main topic of this presentation, is not the validation, but how we were able to provide a nice algorithm to test as many patients as we can. So by the end of the second day, our assay was validated on the Roche MagnaPure 96 using a high throughput extraction platform, and it was cross-validated on the Thermo Fisher ABI 7500 system, as well as the ABI QuantStudio DX and the Roche Cobas Z480 as amplification and detection platforms. Now, just to let you know, the Lyra assay is as well EUA approved on the Biorad CFX 96 Touch and the QIAGEN Rotor Gene-Q. This is just a representation of our operation. So this is the pre-PCR room. Like any molecular pathology division, we have pre-PCR and post-PCR operation. So these are what I'm showing you are angles or sections which basically are involved with the COVID-19 testing, showing the biological safety hoods and all the precautions with our staff and employees taken when basically processing and prepping COVID-19 testing. This picture over here represents our high throughput extraction room. These are high throughput extraction platform, and these are the Roche MagnaPure 96 platforms, which are basically mainly used to extract 96 well plates, extract RNA from these 96 well plate. Those pictures are taken from the post-PCR room, which, as everybody knows, these rooms basically include or house the platforms for detection and amplification. And as you can see in both pictures, I'm showing two different QuantStudio DXs, one 7500 platform and the box in white, which is the Cobas Z480. So these are our amplification and detection platforms. Now, for laboratories that do not have the big extraction platforms that I showed on the second set of pictures, Quidel has developed the Lyra Direct SARS-CoV-2 assay. This assay is extremely similar to the original Lyra SARS-CoV-2 assay. Is just the only thing that's different is that it does not require an extraction. Instead of like going through an extraction, the specimens are only exposed to 10 minutes heating and another 10 minutes cooling, then go straight on the amplification and detection platforms. So after validating our assay, and the EUA was granted to Quidel on March 16, we flipped the switch on March 17 at MedStar Health to start testing for COVID-19. But our main concern was that we might be short on reagents going forward. So the MedStar Health system leadership has decided strictly to offer testing on symptomatic patient under investigation. And these are the patients that were basically getting ready to be admitted at the hospital, patients that were symptomatic with mild or severe symptoms, because at that time we didn't know how the disease was progressing. So any patient that was showing up symptoms was almost getting ready to be admitted at the hospital, rather than sending them home and their situation getting aggravated and coming back to the hospital. The other population was the symptomatic patient to be tested are the patients that are in the hospital that are symptomatic, and in addition to hospital associates. These are the three populations that in the beginning we have decided to test in all MedStar hospitals. So for 8 days, we have proceeded with that protocol, and we were seeing an increase every single day. But the worst day actually was March 25th, when we have, by the end of the day, confirmed 83 new positive cases out of 273 patients that were tested. It was a very alarming and concerning outcome. At that time, the leadership that night has basically met, and they have decided that more testing was needed. Like any molecular pathology division, we function 5 days a week. We have switched that operation from 5 days a week to 7 days a week overnight. But it was very concerning for me because I felt like my staff was sprinting a marathon at this time being, because this was known that this process was going to be a long process. It's not like it's going to be 2 to 3 weeks. So we had basically to scramble and make sure that everybody was ready to take over this task. During that time, we have designed a process in the lab because we wanted to make sure as well that the clinicians would know when to expect their results when the specimen is collected and submitted to the lab. So during weekdays, we have come up with 2 cutoff time processes. Specimens that were received by 10 a.m. in the morning would be processed on that day, and the results will be available on the same day by 3 p.m. Then all the specimens that are collected between 10 a.m. and 2 p.m. will be processed and completed on the same day before 7:30 p.m. So clinicians would know that if their specimen has been collected at a certain time, when to expect the results. On the weekend, because we were less staffed than during weekdays, we had only 1 cutoff time, that specimens that were received at 10 a.m. in the morning will be resulted same day at 3:30 p.m. Now, how did we come up with that process? It was very simple. It's basically based on the time that was needed to complete those assays. So if you look at the right-hand side of the slide, you can see a nice sketch showing the steps of the process. But as well, I have outlined mainly what's needed for this test to be completed. So for us, in order to have the plate ready and the specimens dispensed in the plate, we needed almost like 90 minutes to have that ready. And then the extraction took another 60 minutes. Setting up the PCR and programming the platform was 45 minutes. And then the runtime for the assay on any of these platforms was almost like 80 minutes. So the assay was solidly almost taking 4.5 to 5 hours maximum. So this is why we have set these timelines that if we receive a specimen by 10 a.m., it will be ready by 3 p.m. or by 2:30, it will be ready by 7:30 p.m. That process basically went smoothly between the 2nd week of March all the way to the 2nd week of April. And we have kept testing only those 3 populations of patients, and testing was only done in the molecular pathology division. Then on the 3rd week of April, we had a good news. All the companies that promised us to provide us with rapid testing for COVID-19, these platforms and these assays were shipped to our hospitals. Now, these assays that were not done in the molecular pathology division, they were done on microbiology benches. And these were like rapid assays that required very minimum handling. But the biggest problem was that limited reagents were available during that time for all these rapid assays. We validated these assays, and the material that was used for these validations were specimens that were previously tested using the Lyra SARS-CoV-2 assay. Now, with the presence of all these assays, the MedStar leadership has identified different categories of patients to be tested. So of course, we have our hospital inpatients. These are the symptomatic inpatients, regardless of their COVID-19 status. We have the patients that were getting ready to be discharged from the hospital that had to be tested because we wanted to make sure that any patient that's being discharged is negative and it's not basically sent into the community with a positive result. And also the patients that were coming through the ER department, the emergency department, and getting discharged from the emergency department, we wanted to make sure that these patients as well were being tested, because the emergency department was basically a hub for COVID-19 at that time. Now, two categories of patients were added, and those are the patients that were under investigations and the emergency surgery patients. During, this time, we wanted to make sure that emergency surgeries like labor and delivery, transplant surgeries, trauma surgeries had to be basically available in the hospital and not let patient die because of a trauma, or even like a transplant, or even if a lady needs to deliver, to make sure that we can admit these people to the hospital and make sure we test them adequately without having the staff or the physicians or the nurses at a certain risk of getting COVID-19. So this was the first algorithm that was set by the MedStar leadership, that basically we have two testing methods. We have the routine method, which is the 24 hours turnaround time, and then we have the rapid COVID-19 testing, which are 2 to 3 hours turnaround time. The routine testing was done in the molecular pathology division using the Lyra SARS-CoV-2 assay, and the rapid testing were done using the GeneXpert and the QIAstat assays. Now, which populations had to be assigned to these assays? Patients that were in the hospital or discharged patients or emergency department discharged patients, those do not need results as soon as possible. So they have assigned these patients to be tested in the molecular pathology division using the Lyra SARS-CoV-2 assay. On the other hand, patients that were under investigation and that were ready to be admitted into the hospital, or patients that had emergency surgeries, had to be tested using the STAT turnaround time assay, because we wanted to make sure that these patients were directed to the appropriate floors. If they were positive, these patients would go into isolation floors. If negative, these patients will go to different floors. And just as a reminder, at that time, we were dealing with a lot of shortage with PPEs as well. So this is why we wanted to make sure that we can identify these patients so that a lot of PPEs is not used in the wrong place. What was the outcome of this algorithm? So definitely we have increased the testing capacity. But what happened is that a lot of doctors were ordering the rapid test rather than ordering the routine test because they wanted their results quicker. That created a problem. One, basically the rapid test was being depleted in the system. Then the companies that were providing us with these rapid assays, because there was so much demand on their assay and because their assays could be handled by hospitals that did not have molecular labs, they put us on further allocations. So we did not have enough of these testing anymore. So we had to come up with stricter criteria for these rapid COVID-19 assays. So the clinicians had to go and select a specific reason for them to order the rapid assay. And if that reason was not justified, it will direct the test directly to the molecular pathology division, which is the routine test. These algorithms were basically mainly discussed by the system leadership, by the chairs of the infectious disease departments, pathology departments, and the chief medical officers of all MedStar hospitals. During that time, that process was basically smoothed and the rough edges were smoothed as well. So we were heading in the right direction and we were testing a good number of patients. Until the second and third week of May, when the restrictions in the state of Maryland and DC were lowered a little bit, or like basically were more at ease, the MedStar hospital decided to open their doors for elective surgeries. At that time, we have identified a patient population called the preoperative population. These patients that are going to come into any MedStar hospital to have their surgeries performed, they will come and get tested for COVID-19 72 hours to 48 hours prior to their surgery, and then they will go home and get quarantined until they have the results, or until they get their surgeries done as well. At the same time, MedStar urgent care facilities were equipped as well with the Abbott ID COVID-19 assay, and they have their doors open for all patients to come in and then get either the COVID-19 assay or for any other reasons that you need to go to an urgent care facility. And during the third week of June as well, we have acquired another platform that tests the COVID-19 assay, which is the Diasorin Liaison MDX. So now we have multiple assays and multiple platforms included in our system, and we were comfortably able to test higher capacity of patients. And the current algorithm for our testing is the following algorithm that you are seeing in front of you. We have 3 major testing platforms or testing facilities. The molecular pathology division that uses the routine testing with the Lyra SARS-CoV-2 assay, the microbiology benches that use the rapid testing, and the urgent cares that are basically equipped with the Abbott ID SARS-CoV-2 assay. And you can see under the molecular pathology division, we test the MedStar hospital inpatients, the emergency discharge, and the hospital discharge, as well as the preoperative patients. Whereas with the rapid COVID-19, we test the PUIs and the emergency surgeries. So from March until this day, we have tested so many patients, and these are some of the numbers we have basically established during this time. And you can see with the Lyra SARS-CoV-2 assay, we have tested a total of 48,682 patients. And then we have a 3.6% positivity prevalence with this population. But of course, they're divided differently between different patient populations. Now you can see the symptomatic inpatients have the highest percentage, and that's absolutely normal. But also this high percentage is because these patients were tested as well on different frequencies. So it's not like they were tested once, they were tested multiple times during their stay in the hospital. And that frequency was different depending their disease progress. In this slide over here, I'm gonna be showing you the numbers of all testing that were done at MedStar Health, in the MedStar Health system using the different assays and the different platforms. And you can see like the total number is pretty high for a healthcare system. And we have so far almost tested approximately 140,000 tests with a positivity percentage of 2.8%. So this process currently is still basically followed is followed with the same algorithm that I have showed you. And we are testing almost close to 4,500 patients a week in our system. And I want to thank everybody for attending this presentation, and I'm open for any questions. Thank you.